Good afternoon, my dear colleagues, my dear friends. Today we will continue our webinars, and today we will talk about drug-induced Brugada syndrome. It's an important syndrome. Last time we have talked about drug-induced QT prolongation. Today we will continue drug cardiotoxicity and problems which can happen in patients because of drug-induced. For our new participants, let me introduce myself. My name is Galina Cordero. I am a medical doctor, master's degree with scientific background, qualified person of pharmacovigilance, head of pharmacovigilance department, and clinical expert, GVP.Фармак. Brugada syndrome, it's a complicated syndrome. It's because not many doctors know about these consequences of drug-induced adverse events, and I would like to pay attention that exactly genetic polymorphism and mutation of 12 of genes play important role in pathophysiology of this syndrome. Brugada syndrome is an inherited cardiac arrhythmia syndrome that is associated with CT-ST segment elevation on right precordial leads and a relatively higher incidence of sudden cardiac death. Brugada syndrome characterized by an electrographic ECG pattern manifested as prominent G waves, giving the appearance of an CT segment elevation in the right precordial leads on ECG. Diagnostic criteria require the presence of a cover type ST segment elevation with a J point elevation more or equal to millivolt. It is also characterized by ventricular arrhythmias, atrial arrhythmias, syncope, and sudden death. Its party can happen as a result of Brugada syndrome. The diagnosis in an individual requires the presence of the Brugada syndrome, EGG pattern as described above type 1, with at least one on the recognized diagnostic criteria. Syncope, prior cardiac arrest, documented or inducible polymorphic ventricular tachycardia or ventricular fibrillation, a family history of sudden death, less than 45 years old, or type 1 Brugada pattern, and or nocturnal agonal respiration. Brugada syndrome, when it can happen, it involves right ventricular disease because it's more prominent in the right ventricle. It is also much more prominent in the pericardium than in the endocardium, which is responsible for the prominent AP notch in the pericardium but not the endocardium. This heterogeneous distribution of ITO and IP notch is responsible for inscription of the J wave. Brugada syndrome is thought to account for 18% of unexplained sudden cardiac death. Sudden death predominantly occurs at rest or during sleep. The disorder has an age-dependent and sex-related penetrance, resulting in most lethal events occurring in men after the fourth decade of life. Genetic variants in SCN5A that encodes that alpha subunit of the cardiac sodium channel are the predominant genetic cause of Brugada syndrome, but account for only approximately 15% of cases. New insight into the genetic architectures of Brugada syndrome have recently been uncovered through a large international genome-wide association study that showed the common genetic variants have an important role in Brugada syndrome susceptibility. Genetic polymorphism of Brugada syndrome. The majority of patients with Brugada syndrome are caused by mutation in the cardiac sodium channel, gene SCN5A, the gene encoding for the alpha subunit of the sodium channel. The majority of patients with Brugada syndrome are caused by mutation in cardiac sodium channel gene, this gene, SCN5A, and subgroup of familial sudden cardiac death syndrome, in which a Brugada syndrome phenotype is combined with short QT intervals, rate-corrected QT intervals less or equal 360 milliseconds has been identified. In these patients, loss of function missense mutation of CACNA1C, A39V, and G490R, and CACNB2 as 481L, encoding in the alpha-1 beta-2b subunits of the L-type calcium channel have been found to be the underlying cause. A mutation in the glycerol 3-phosphate dehydrogenase 1 like GVP.1L gene has also been identified as less common cause of Brugada syndrome. The mutation of GVP.1L gene causes a decrease in the SCN5A surface membrane expression and a subsequent reduction in the inverse sodium current across the cell membrane by as much as 50%, resulting in the phenotypical appearance of Brugada syndrome. The mechanism by which GVP.1L mutations alter the sodium channel membrane expression is currently unknown, although alteration in the cellular oxidative state has been suggested. Brugada phenotype is more prevalent in males and is a result of presence of a more prominent I2 channels in males than females. Carriers of the condition are at higher risk of ventricular tachycardia, ventricular fibrillation, and sudden cardiac death. Syncopal episodes and paroxysmal palpitation are the only symptoms the patient may have before sudden arrhythmic death occurs. Brugada syndrome is estimated to be responsible for at least 20% of sudden death in patients with structurally normal hearts. In region of Southeast Asia, where it is endemic, the clinical presentation of Brugada syndrome is distinguished by a male predominance, around approximately 8:1 ratio of male-female, and the appearance of arrhythmic events at an average of 40 years, range 177 years. Brugada syndrome and mutation of genes has been associated with mutation in 12 different genes. More than 300 mutations and CCN5 have been reported. Around 11-21% of Brugada probants. Mutation and CACNAC, CACNB2B, and CACN2D1 are found in approximately 7 and 13 of probants. Mutation in the glycerol 3-phosphate dehydrogenase 1-like enzyme gene GVP.1L bear C2, the beta-1 subunit of natrium channel, and it has CN1B, bear C5, KCN3, MIRP2, Brugada syndrome 6, the beta-3 subunit of natrium channel, SCN3B, KSNG8, and KSND3, MOG1, and SLMAP are more rare. Mutation in these genes lead to a loss of function in sodium channel current I natrium and calcium channel current I calcium, as well as a gain of function in the transient outward potassium channel I2 or adenosine triphosphate. Sensitive potassium current ITP and acquired forms of Brugada syndrome mimic some forms of the congenital syndrome by reducing IN1 and ICA and by augmented ITO and IT. Why it's important? Because when we're talking about genetic polymorphism, genetic mutation, now it's a very important question, because patients will need gene sequestration and to see real picture of mutation. And I think it will be future of medicine. Many countries already do is gene mutation, show gene mutation by gene sequestration, and it show even that sometimes prescribing one drug, it can be a more effective than 3 another one prescribed to this patient, because medical doctor know real picture of genetic sequestration. And this importance I will show in my next lectures, and it will be talking about pharmacogenomic and genetic polymorphism and role of gene mutation in drug-induced disease. Please follow me, and I think this knowledge will be important and useful in your practice, in daily practice. Patho-mechanism of Brugada syndrome. Three mechanisms are proposed for ST segment elevation Brugada syndrome. It's local conduction abnormality, local ventricle depolarization, and early repolarization abnormality. The latter hypothesis postulates an accentuation of the action potential notch in the right ventricular epicardium carried by the transient outward current I2 via reduction in the fast sodium inward current I natrium. A reduction in I natrium or L-type I calcium or an increase in I2 dominant at epicardium would produce a striking abbreviation of epicardial action potential, which would lead to an epicardial endocardial heterogeneity of repolarization that would cause ST segment elevation. A genetic defect in the cardiac sodium channel gene SCN5A may lead to a reduction in the transporal sodium and voltage gradient, which is normally responsible for the inscription of the J wave, giving rise to a saddleback form ST segment elevation if the epicardial repolarization precedes repolarization of mid and endocardial regions. First, accentuation of the notch accompanied by a prolongation of the epicardial action potential may lead to the development of COVID-type ST segment elevation. Ultimately, a loss of the action potential dome at some epicardial site may result. The marked intramural dispersion of repolarization may be responsible for local re-excitation via phase 2 re-entry. When coupled with extrasystoles capable of initiation circus movement, a re-entry arrhythmia can be triggered. Pharmacological agents that primarily block I natrium but not I2, it can be flecainide, idmyline, and procaminamide, can first diminish sodium current already reducing by the Brugada syndrome. This hypothesis may explain the use of sodium chain blockers to unmask a concealed form of the Brugada syndrome and the potential pro-arrhythmic adverse effects of this and other pharmacological agents. You see how it looks like an EGG Brugada syndrome. Electrocardiographic recording is a pulsicainide, a challenge test in a patient with Brugada syndrome. At baseline and saddleback time ST segment type 2 is present in the right precardial leads B pictures. Intravenous administration of pulsicainide 50 mg converts type 2 ST segment elevation to a COVID type ST segment type 1, thus unmasking the Brugada syndrome phenotype. Brugada syndrome mimicry. It is important to exclude other conditions that may mimic the Brugada EGG patterns. This includes structural disease that may be hereditary, arrhythmogenic right ventricular cardiomyopathy, or acquired acute myocardial infarction or ischemia of the right heart, pulmonary embolism or cardiac compression, and similar ECG patterns in normal hearts. Early repolarization syndrome, electrolyte imbalance, or hypothermia. They are separate clinical entities and have different pathophysiologies and prognosis. Drugs that can cause the Brugada phenotypes are sodium channel blockers, class 1C drugs, pulsicainidine, flecainidine, propafenone, class 1A drugs, ijmaline, propiamide, disopyramide, and ziberzoline. Class 3 drugs, amiodarone, calcium channel blockers, verapamil, beta blockers, propranolol intoxication. Anti-anginal drugs, calcium channel blockers, it can be nifedipine, ditilzam, diltiazem, potassium channel openers, nicanandil. Psychotropic drugs, tricyclic antidepressants, amitriptyline, nortriptyline, desipramine, clopramine, phenothiazine, selective serotonin reuptake inhibitor, fluoxetine, lithium, anticonvulsants, oxcarbazepine, clonazepam, antipsychotics, trifluoperazine, loxapine. Other drugs, anesthetics, bupropion, propofol. Propofol is included in the list of drugs that can cause the Brugada phenotype. Histaminic H1 receptor antagonist, acetylcholine, edropronium, cocaine, and alcohol. Antiarrhythmic drugs, sodium and calcium channel blockers class 1C and class 1A. Pharmacology challenged by the several sodium channel blocker is established tool for diagnosis of Brugada syndrome. Sodium channel blockers such as pilcicyanide, imaline, and flecainide are capable of inducing ST segment elevation and unmasking cancelled Brugada syndrome phenotype. Pilcicyanide is a class 1 sodium channel blocker antiarrhythmic drug for treatment of atrial tachyarrhythmias, including atrial fibrillation. Pilcicyanide intravenously at a dose of 1 mg per kilogram over 10 minutes. After administration, the J point and ST segment are elevated and display a covert type or type 1 ST segment elevation. Sodium channel blockers can unmask a type 1 ST segment elevation or convert a type 2 saddleback ST segment elevation to a type 1 Brugada syndrome pattern, as in the case. Pilcicyanide as well as other sodium channel blockers, including propafenone and flecainide, can cause the appearance of Brugada syndrome ACG when it is routinely used for the treatment of atrial fibrillation. A covert type with T segment elevation in the right precordial leads was induced or enhanced in 22 patients following imaline administration, but only in 15 patients is response for flecainide. Blockage for I2 counters the effect of the drug and cause an outward shift of the balance of current activity during the early phases of AP. To our knowledge, there are no idea relatively to pilcicyanide blockage of ITO. Pilcicyanide may be the most powerful agent for unmasking Brugada syndrome, although a direct comparison between imaline and pilcicyanide is not available. Calcium channel blockers. Mutation in CACNAC1C, Brugada syndrome 3, CICNB2B, Brugada syndrome 4, and CACNA2D1, Brugada syndrome 9, have been associated with Brugada syndrome is approximately in 13 proband. Experimental models have shown that verapamil accentuates the epicardial AP notch and produces the Brugada syndrome phenotype. The use of a combination sodium and calcium channel block may be more effective than the use of sodium channel blocker alone in causing the Brugada phenotype. Verapamil can cause CT segment elevation and permit the induction of programmed electrical stimulation induced VF in case of Brugada syndrome. Beta blockers, isoprotenolol ICO, exert ameliorative effects on Brugada syndrome. Beta adrenergic blockers may exert a proarrhythmic effect. Propranolol, a non-selective beta-1 adrenergic agent, was reported to cause a Brugada syndrome pattern on ECG during intoxication. Higher concentration of propranolol can inhibit I natrium, leading to the outward shift of the current active during phases 1 and 2. Anti-angial drugs, ATF-sensitive potassium channel opener. ATP-sensitive potassium channels are found in the heart, pancreas, smooth muscle, skeletal muscle, brain, and kidneys. Kalium ATP channel consists of 4 pore-forming KIR6X subunit and 4 regulatory ATP sensing sulfonylurea receptors or X subunit. KIR6.2 KIR6.1 is encoded by KSNG11, KSNJ8, respectively, while SUR2A, SUR1 is encoded by ABCC9, ABCC8, respectively. IKIT agonists such as nicanrandyl exert the anti-anginal action by causing vasodilation and improving coronary blood flow. Mutation in KCNJ8, the gene encoding KIR6.1 and IBCC9, the gene encoded the ATP sensor subunit SUR2A, have been reported to cause a gain of function of IKA ATP and thus contribute to the development of Brugada phenotype. The kalium ATP channel is activated by reduction of intracellular ATP. This appears to be more readily achieved in the epicardium than in the endocardium pinocidal, and IK ATP channel opener has been shown to induce the Brugada phenotype in experimental models of Brugada syndrome. There are only a few cases reported of Brugada phenotype being induced by anti-angiogenic drugs alone. However, a combination of nifedipine and isosorbide dinitrate (ICDN) has been reported to induce a Brugada phenotype. Cases of coexisting vasospastic angina and Brugada syndrome have also been reported. Acetylcholine-induced coronary vasospasm has likewise been reported to cause a Brugada syndrome pattern on ECG. However, the coexistence of coronary vasospasm and Brugada syndrome is rare. Psychotropic drugs. I won't pay attention on tricyclic antidepressant, amitriptyline, nortriptyline, diazepamide, and clopidogrel. Psychotropic drugs are well recognized to induce cardiac arrhythmias and cause an ST segment elevation consistent with Brugada syndrome. Tricyclic antidepressants have been reported to induce the Brugada patterns on ECG over a wide range of an antidepressant dosage. Amitriptyline, a tricyclic antidepressant, has recently been reported to induce the Brugada syndrome phenotype in clinics. Amitriptyline was shown to cause an outward shift in the balance of current activity during the early phases of the epicardial IP by reducing the peak sodium channel current. Amitriptyline has an effect on the reduction of INA and introduction of Brugada phenotype in a right ventricular vein with NC5806 I2 agonist caused loss of the IP dome in API2 and led to phase 2 re-entry and polymorphic ventricular tachycardia. VT. Amitriptyline alone did not induce any arrhythmias, suggesting that amitriptyline-inducing inhibition of INA unmasks the Brugada ECG phenotype and facilitates the development of an arrhythmogenic substrate only in the setting of genetic predisposition by creatine repolarization heterogeneities that gave rise to phase 2 re-entry and VT. Amitriptyline can also block ITO, explaining why it fails to induce the Brugada syndrome phenotype even at higher concentration. Lithium is widely used to treat depression and bipolar disorder. The lithium-induced Brugada syndrome phenotype is not common, but it can be observed even with use of therapeutic dosages. Lithium also causes other conduction dysfunction, such as sinus node dysfunction, conduction block, and ventricular arrhythmias. Lithium has also been shown to block I natrium in dose-dependent manner. Lithium has been associated with non-specific T-wave abnormalities, inverted, flattened, or beefed T-waves without QT prolongation. Other conduction defects and rhythm disturbance have also been reported, including sinus node dysfunction, atrial flutter, anteroventricular block, right bundle branch block, left anterior hemiblock, and ventricular tachycardia and ventricular fibrillation. Recently, 2 cases of lithium therapy unmasking the type 1 Brugada ECG pattern have been reported, both with other features suggesting the Brugada syndrome. In one of the patients, the type 1 pattern occurred when lithium levels were therapeutic. Lithium withdrawal in both patients resulted in resolution of ECG abnormalities. In Chinese hamster or ovary cells transfected with SCN5A, which encodes the cardiac sodium channel, lithium chloride caused pattern cardiac sodium channel blockade in a concentration-dependent manner at level well below the therapeutic range IC50 or 6.8 plus minus 0.04 millimole per liter. This is the probable mechanism of action in unmasking pattern masking patient with underlying Brugada syndrome. Whether the induction of the type I1 ECG pattern in patients without other features of Brugada syndrome indicates an increased risk for sudden cardiac death is unclear. Selective serotonin reuptake inhibitors. Data regarding the selective serotonin reuptake inhibitors induced Brugada syndrome phenotype are scarce. Paroxetine and fluvakamine have been shown to lead a Brugada pattern in ECG via reduction I natrium channel. Anticonvulsant, antipsychotic, phenytoin is antiepileptic agent. There are cases reported of Brugada syndrome caused by supratherapeutic phenytoin levels in a patient with a seizure disorder. There are several reports of ECG signs of Brugada syndrome in cases of hyperkalemia in conjunction with psychotropic drug overdoses, notably phenothiazines, antihistamines. The Brugada type 1 ECG has been elicited in patients treated with first-generation antihistamines. One patient receiving intravenous infusion of dimenhydrinate for the treatment of labyrinthopathy developed a transient cover-like ST elevation in the right side precardial lead. Also, the patient had no history of syncope and no family history of cardiac disease of sudden death. The ECG abnormality was reproducing with intravenous flecainide, and asymptomatic Brugada syndrome was diagnosed. In another case report, a 39-year-old patient with an overdose of diphenhydramine became unconscious and hypertensive and subsequently developed the type 1 ECG pattern. His serum potassium concentration was 8.3 milliequivalent, but the ECG abnormalities failed to settle despite correction of the hyperkalemia and intravenous infusion of isoprotenolol. They subsequently normalized spontaneously. A negative flecainide test suggests that these transient ECG abnormalities were the consequence of the drug's overdose and not the unmasking of underlying Brugada syndrome by diphenhydramine. Anesthesia. Anesthetics such as propofol and bupivacaine are commonly used in clinical settings. Bupivacaine was reported to induce the Brugada phenotype in silent carriers of an SCN5A mutation. In other reports, also demonstration bupivacaine-induced Brugada phenotype that normalized following drug withdrawal. Propofol has been reported to cause sudden cardiac death in 1 non-genetic and 6 unclear cases. Propofol has been shown to inhibit neuronal sodium channels, but there are no data relative to cardiac sodium channels. It is unclear whether a genetic predisposition is present in those who display a Brugada syndrome phenotype after propofol administration. Bupivacaine, also class 1A and 1C antiarrhythmic agents, have been used to identify cancelled Brugada syndrome. Lidocaine, also used as local anesthetic, does not. Similarly, mexilatine, a class 1B sodium channel blocker, has not been reported to induce Brugada ECG. On the other hand, exposure to the long-acting local anesthetic, bupivacaine, has been reported to induce ECG manifestation of Brugada syndrome and ventricular tachycardia and otherwise silent carrier of SCN5A mutation. The mutation was shown to reduce the sodium current one-fold patch clamping. In another report, a patient developed the type 1 ECG pattern after receiving a continuous epidural bupivacaine infusion. After withdrawal of bupivacaine, the ECG changes reverted back to baseline. Unlike lidocaine, bupivacaine causes greater depression of the rapid phase of depolarization and Purkinje fibrils and ventricular muscle and remains bound to the sodium channel for a longer period of time. This may explain its ability to induce arrhythmia in patients with cancelled Brugada syndrome. Propofol. 6 of the propofol infusion syndrome patients developed the Brugada-like ECG and died within hours of a reconvertible electrical storm, whereas none of the 60 other patients developed ventricular arrhythmia, suggesting that the mechanism underlying the arrhythmogenesis in propofol infusion syndrome is similar to the responsible for ventricular arrhythmias in the Brugada syndrome. Dear colleagues, thank you very much for your attention. I will be very thankful for your describing on my YouTube channel. It will increase ability for medical doctors, pharmacists, healthcare professionals, and especially from pharmacovigilance and pharmaceutical industry to get ability for this drug safety knowledge. And we have families, we can be doctors, we can be pharmacists, we can be pharmaceutical specialists, but still we can be patients, and we should know how to avoid adverse events. We should know how to help patients, and I want that my lectures will increase safety of patient, because my main aim of these lectures is create a culture of safety prescribing, of safety using medical drugs, medicines, and we remember that safety of patient first. I will be waiting you on my new lectures. I will be thankful if you will ask questions, because I want that lecture will be useful precisely for you. Thank you very much. I will be waiting on my lectures. Please subscribe on my channel. Bye bye.